Thanks so much, Paul, for this kind invitation. It's particularly meaningful given my professional relationships with Andy and Craig. So Andy's been really instrumental in my career. I first met him when I was a fellow on the CALGB, at that time, lymphoma committee, and got to know him there. And then when I moved to Rochester, I maintained my involvement in the NCCN lymphoma outcomes database. And I'd say Andy was maybe one of two people who was really instrumental in my learning how to do that type of research and interpret the data. And then moving on to the National Lymphocare Study, similarly, he was a great advisor and really had great insightful points, and always look forward to the meetings with him. Craig's been similarly somebody who I've always looked to for advice and input on management of patients with Hodgkin lymphoma, and perhaps his most important accomplishment is training Dr. Casulo, who's been a fantastic addition to our faculty and is really rising, I think, in the field of lymphoma. So it's particularly meaningful that I'm here. I think for a talk that's called Trials and Tribulations and Moving Beyond R-chop, we have to start with this curve. This, of course, was from the high priority trial that compared CHOP to 3 different aggressive regimens. And again, the history here was that these 3 aggressive regimens in phase 2 trials all looked superior to CHOP, but when they were compared head-to-head, there was no difference. Retrospectively, once the IPI had been identified, you could easily explain why those prior phase 2 studies looked so positive because of patient selection. So I think it emphasizes the challenge. The development of these 3 regimens took many years and hundreds, if not thousands, of patients, and there was no improvement. Since this publication, there have been numerous other attempts that are really in similar lines, and perhaps not surprisingly, there haven't been improvements yet to date. CHOP was escalated to given every 14 days rather than every 21 days. The addition of etoposide to CHOP with the CHOEP regimen, and more recently the EPOCH regimen. And besides for the EPOCH, all the other ones, when they've been tested in a randomized way, have really shown, again, no superiority over CHOP. We're going to see data at ASH on the EPOCH study. I'm not terrifically optimistic that's going to change care. So thousands and thousands of patients have gone through these types of trials, and we haven't really improved things, with the exception of rituximab. And you heard about this from David earlier, but the addition of rituximab does improve progression-free and overall survival in diffuse large B-cell lymphoma. So how do we move beyond now R-chop in the treatment of DLBCL? And I'm going to really kind of take you through a couple of cautionary tales, and then we'll think about maybe at least emphasizing the challenges to try to accomplish this. So we know diffuse large B-cell lymphoma is a heterogeneous disease, and appreciating this both clinically and genetically and perhaps molecularly is hopefully going to be our answer to getting beyond R-chop. So this disease can be divided through various clinical prognostic schemes. In this particular one, using what's called the NCCN IPI, the highest risk group had a 5-year overall survival of only 38% compared to the low risk group. And you can see that about a third of patients are in these 2 high risk groups that are easily identified, and perhaps easiest to try to beat R-chop because the bar is lower and there are more events to be had. So one story that took advantage of this is a story about PKC-beta and a drug called Enzastaurin. So many years ago, using gene expression profiling, Margaret Shipp and her group compared patients who were cured with diffuse large B-cell lymphoma to those who died or had refractory disease. This is a different type of analysis from the cell of origin analysis. And there were a number of genes that were enriched in the patients who were cured and a number of genes that were enriched in the fatal refractory, and one of the ones that was enriched was this gene called PKC-beta. Subsequently, she did staining and demonstrated that patients with high-risk disease had increased PKC-beta expression, and those patients did worse than patients who did not have that expression. There was a drug that was being developed for diabetes called Enzastaurin. So this was a PKC-beta inhibitor. It made sense to potentially try this. And in a phase 2 trial, in a similar development scheme that often happens in lymphoma, there was a study done. A relatively small number of patients responded and had prolonged freedom from progression. Some of these patients were essentially either cured or potentially, their disease remained quiescent for years. So there was enthusiasm that this drug did have activity in a subset of patients. The company took this drug then to a phase 3 trial. This was a randomized trial that was enriched for this fatal refractory signature, not molecularly, not genetically, but clinically. So they enrolled patients who had high intermediate or high IPI, but who responded completely to induction therapy with either R-chop 14 or 21. And the patients were randomized to Enzastaurin or placebo. This was a very large trial of over 700 patients. So again, emphasizing all of these patients had high intermediate or high risk IPI at diagnosis. And the primary endpoint was disease-free survival. And even with this large trial, they were looking at a fairly substantial improvement. They were looking for a hazard ratio of 0.68. So, published a few months ago was the final results of this trial. Totally negative trial, overlapping curves. An important point to make in this trial is that the trial had to be expanded because of a low event rate. And I think you can see that whether you're in the placebo group or in the Enzastaurin maintenance group, these curves look pretty good considering all of these patients had high risk or high intermediate risk IPI at diagnosis. So there's a reconciliation that needs to be done, and we'll come back to why perhaps that is. And they went on to look at subsets because there was an appreciation that maybe this drug might have particular activity in the ABC subset, and at least using immunohistochemistry on a subset of patients that were enrolled, not all the patients. There are really no appreciable differences any way you try to divide this up. So why didn't this work? It's an important question if we're going to try to improve on R-chop to learn lessons. So I'd say the first thing is the targeted population here was defined clinically, not genetically or molecularly. And when they look back, only 22% of the patients had increased PKC-beta expression. Interestingly, they then went on and looked in that subgroup of the 22%, and even there was no signal that this had any activity. I think another important message here is that most failure events in diffuse large B-cell lymphoma occur early. This was a maintenance trial, and you lose probably the majority of the events in high-risk patients by waiting until a patient is in a CR before you enroll that patient. The event rate, as I said, was therefore much lower than expected, probably because of this and because of complexities of enrolling patients in clinical trial. If you look at populations, many high-risk patients with diffuse large B-cell lymphoma are elderly patients who wouldn't even be considered for a trial like this. Age, of course, is in the IPI, and extranodal disease and high LDH and poor performance status tend to track with graying patients or older patients. So therefore, when you look at a curve from a population study and you say, well, a high-risk patient only has a 40% chance of cure, and then you do a trial and there's a 70% chance of cure, probably a lot of that is because of patient selection. So this drug isn't going anywhere. So we heard earlier about the importance of the cell of origin, and maybe that's a way that we can we can exploit the cell of origin to try to improve upon R-chop. Just remind you that there are a number of different signatures that can be looked at. In addition to ABC and GCB, there are stromal signatures that have been associated with either favorable or poor outcome. And there are a number of ways you can do this to try to find patients who are at high risk of failure. And of course, the advantage here is that you have gene signatures that may be able to help you choose drugs that are rational for subpopulations of diffuse large B-cell lymphoma. So can we move beyond R-chop in diffuse large B-cell lymphoma using cell of origin for treatment decisions? There are a number of challenges in my mind to this as well. So again, the majority of the patients that we see are cured with our current therapy that's completely empirically derived. That means that if we're going to use a precision approach, especially to a population, there's a high bar to demonstrate success. And again, many of the failures are occurring in frail and elderly patients that aren't even necessarily approached with curative intent. I think the other critique has been that at least to date, many of the novel therapeutics that are used have pleiotropic effects, which really limit a true precision approach. That's probably evolving. But to say a drug like lenalidomide is good for non-germinal center diffuse large B-cell lymphoma, I mean, lenalidomide does so many things that you can pick one pathway that you think is the major activity, but maybe the immune effects of lenalidomide are overcoming whatever that pathway is doing. And I think the other reality is, perhaps not here, from at least the cases this morning, but clinical grade gene expression profiling in real time is not widely available. And so therefore, immunohistochemistry surrogates have been developed, and there are challenges of using immunohistochemistry surrogates in this setting. And I'll just remind you that when you do gene expression profiling, we always talk about ABC and GCB, but there's this third group called unclassified diffuse large B-cell lymphoma. And variably, that makes up between 15 and maybe 25% of diffuse large B-cell lymphomas in that group. It's usually thrown out when you're doing these analyses. But when you use immunohistochemistry, this is the Hans algorithm of germinal center versus non-germinal center, there is no unclassified category. So you're forcing these cases into one of these two columns, depending on how you define your algorithm. Often these cases are forced into the non-GCB column if you're using Hans. That, in a way, is contaminating your precision approach. And it may be that that explains to some degree why there's such differences seen in outcome when you're using a categorization that is immunohistochemistry versus true gene expression profiling. So proteasome inhibitors were one of the first agents that were evaluated using cell of origin, and that was based on an early study from the NCI, single institution trial that combined bortezomib with dose-adjusted R-epoch in a single-arm study. It was a complicated study. They had a window where they gave bortezomib alone, and then they came in with chemotherapy. The bottom line is that the patients with non-GCB, or some patients that actually had gene expression profiling with true ABC disease, did better than the GCB. And that's, of course, the opposite of what we're inclined to expect. Usually the non-GCB does worse than the GCB. In addition, there's a postulated mechanism where bortezomib seems to inhibit elements of the NF-kappa B pathway that we know are enriched in ABC subtype DLBCL. So there was biological mechanism, and there was an observation that this seemed to work, at least in an early phase clinical trial. That data alone led to 4 randomized trials to try to definitively answer the question as to whether R-chop or versions of R-chop with or without bortezomib can improve things. And at ASH this past year, we saw the results of 2 of those trials, or at least preliminary results. And again, there were no differences seen. This was a phase 2 trial, R-chop bortezomib and R-chop, no statistically significant difference. This took out the vincristine, and again, there was no significant difference. So that was quite disappointing. I'll again point you to an observation that, and I should emphasize that this is specific to the non-germinal center subtype of diffuse large B-cell lymphoma. So this was a precision type of approach. If you take a look at these curves, the cure rate here appears to be much higher than you'd expect from the historical data. Again, very similar to what we saw with the Enzastaurin. So it begs the question, why are patients doing so much better on our trials now? And is there even a signal now that on a prospective clinical trial that the ABC patients are doing inferiorly? And again, I think that there are potential selection biases for this. I'll just say at our institution, we've had trials like this open, and my observation is many of the patients who come in the door with non-germinal center diffuse large B-cell lymphoma, they actually don't come in our clinic door, they come in our inpatient door. They're sick, they are in the hospital, and they need treatment quickly. They're not patients that are good candidates for a trial that you have to send a tumor sample off to some laboratory and wait even a few days for a turnaround time. So those patients end up getting screened out. The patients who you're left with are probably these patients who aren't having very many events. And I think that there's this selection bias that's occurring that we don't even appreciate. It wasn't intentional. But in trying to make the study as pure as possible, I think that there are major issues, and I think we may have to tackle novel designs. For example, allowing a freebie course of chemotherapy to try to get a patient started and then come in with a novel agent rather than just feel that everything has to happen from the start. So another story that is still evolving is that of BCR pathway inhibition, and this was one of my patients that was treated on the trial that's already been alluded to twice this morning of single-agent ibrutinib in diffuse large B-cell lymphoma. He happened to have ABC subtype disease. He had a large liver lesion. 8 weeks later, that had a great response. This was multiply relapsed diffuse large B-cell lymphoma. And again, the observation was using gene expression profiling, not immunohistochemistry, that the ABC subset had a much higher response rate and improved overall survival. Now, there were specific mutations that could be defined that could further predict for either resistance or sensitivity to this regimen. So then Anas ran the trial that moved this up front, and in a single-arm study of R-chop plus ibrutinib, interestingly, again, this was a small study, but the CR rate was higher in patients with non-germinal center diffuse large B-cell lymphoma, and that led to this randomized trial that's been completed, but we do not have results yet. The question is, will this work? And I think that, even if it works, the question is, how much will this really impact the disease diffuse large B-cell lymphoma? Keeping in mind that only about 30 to 40% of newly diagnosed diffuse large B-cell lymphoma is ABC subtype. Some of these patients, as I've emphasized, are frail and elderly and are not candidates for curative treatment. R-chop is already curing a subset of these patients, and only a subset of these patients appear to respond to single-agent ibrutinib. If you say that you have to respond to single-agent ibrutinib to get benefit, then it's a particularly small number of patients that are likely really going to be impacted by this treatment. So if we take all of these stories together, both the Bortezomib story and the ibrutinib story, the question is, what are some of the things that we've learned along the way? So we have demonstrated in these trials that you can do real-time molecular classification. That doesn't speak to the patient that I described on our inpatient unit that we don't even enroll in the trial. But for those patients who are enrolled, this can be done in real time. Just to give you a sense, at ASH there was this Remodel B trial that was presented that did this in over 1,000 cases. And this is what the gene expression profiling came back at. So these are newly diagnosed patients walking in the door. 23% had ABC, 44% had GCB, The unclassified group was 19%, and then an additional 14% they couldn't do the assay because of the sample. So glass half full, glass half empty, you can do it, but if you take a look and you're going to focus on this group that you think is high risk, it becomes a rather small group of patients with diffuse large B-cell lymphoma. And again, the inherent delay that's built in whatever algorithm you use, if you do this centrally, probably screens out the highest risk patients. The other thing that's happening now, and this is beyond the scope of my talk, and I guess if Ariella's talk is given, you'll hear more about it, but double hit and double protein patients are now often being approached differently. And in fact, in the currently open US intergroup trial that is asking a similar R-chop with or without lenalidomide question, focused particularly on ABC subtype, there's language in the trial that suggests that if you have double hit disease, that those patients maybe aren't appropriate for the trial and should potentially go on to other regimens. If you start to take out these double hit and particularly double expressor patients, you're taking more events out of these trials that you're asking with R-chop. And the number of true events that are left are probably going to be a fairly minimal number. So that's another challenge today that we didn't have previously. And finally, I'll just observe that all of these drugs, ibrutinib, bortezomib, not even so much, but lenalidomide for sure, when they're active in the relapse setting, it requires continuous therapy, and often the activity is of short duration. All of the enthusiasm for lenalidomide is about the response rate. The PFS is about 2.5 months in that, with that drug. So are we really going to impact the disease by adding this drug to CHOP chemotherapy? It's not so clear to me. Finally, and this is from one of Anis's papers, it nicely illustrates the heterogeneity even within these groups. So we think that germinal center and ABC subtype disease are specific diseases, but if you take a look at mutations or expression of various proteins, there's heterogeneity. I mean, you can see MYC positivity in both GCB and ABC. You can see various mutations in both. So we think we're using a precision approach, but these categories may not lend themselves so well to a precision approach. I think they've taught us a tremendous amount about the biology, but I'm not convinced that this is going to be the way that we can move forward. So you could say that, for example, with ibrutinib, maybe rather than cell of origin, if we did the specific mutation analyses that were demonstrated in the previous talk, with negative selection for resistance, could you then better enrich for response of diffuse large B-cell lymphoma? And I think you probably could. The fear, of course, is you're starting to get to very small numbers of patients, and how practical is that at a population level? So where do we stand with using Genotype? It's being used in many upfront treatment trials. I think we went through many of the limitations. And I'll just emphasize that if we had an active treatment for the double protein or the double expressor positive diffuse large B-cell lymphoma, that would probably deal with the majority of the events that we're seeing with diffuse large B-cell lymphoma treated with R-chop. And that's where our US intergroup is going. So we're currently in a phase 1 setting, trying to develop the combination of dose-adjusted EPOCH-R with venetoclax. That's going to be studied in previously untreated patients with double hit lymphoma and double expressor lymphoma, and these groups are going to be analyzed differently. So there is some precision approach that is being embraced by the NCTN, although it's modest, I grant you. I'll close with just a few thoughts on the mutational landscape. So this was a study that came out last year just looking at the mutational landscape of a group of samples that had relapsed or refractory diffuse large B-cell lymphoma. So what genes are enriched in that group, and then maybe you could use those moving forward. So there's a long list, and that's a theme, right? I mean, we've seen in all the previous talks how many different mutations are present in various cases, and it's a scatterboard. To try to, you have to really use big data analysis to understand if a triplet combination of these mutations might predict for either response or failure of a certain regimen. There's certainly some observations, like recurrent STAT6 mutations were present in 36% of cases. That's potentially a targetable lesion. And then MID88 and CD79B mutations were also heavily enriched. So there certainly are therapeutic opportunities here. I mean, this is the similar diagram from the LYSA group, but if you see within ABC subset how many different mutations are present, I'm not so optimistic that certainly using cell of origin is going to get us much beyond R-chop. And I think that unless you were to come up with some cocktail that treated a few of these groups together, to say that you had a great treatment for this group right here, even if you can target that, it's going to be a very complex way to ever demonstrate that outside of anecdotal experience. And therefore, I think it's going to be a big challenge, and it's perhaps not surprising that there are these trials and tribulations with R-chop. So if I think about where we are today, we're starting to move toward a precision approach. I think many people are treating double-hit lymphoma differently. I put dose-adjusted EPOCH-R, but I think there's an appreciation that R-chop is insufficient, and we don't have a standard, so lots of things are being tried. I think if you take the double hits out, the remaining patients with GCB DLBCL are doing very well with R-chop, and it's going to be very hard to demonstrate that something is better in that group. Perhaps the failures are somewhat enriched by some patients who have occult transformation of follicular lymphoma. I think primary mediastinal is a unique disease, and there are regimens that some people are endorsing for that disease. And then you're left with this ABC category, where things are being studied, and there are questions being asked of R-chop plus lenalidomide and R-chop plus ibrutinib. I think I've shared with you the caveats as to how I think those may turn out, but obviously I'm enrolling patients in those trials, and I think we're eager to see those results. Perhaps in the future, we will be able to do something about the larger group of double expressor lymphoma, and then maybe for the remaining cases, have some unique baskets of mutations that we're able to treat in a unique way. But that's going to take a long time. And I actually was really impressed this morning hearing the presentations and speaking afterwards to Anas about how you here are doing this genotyping in a very routine fashion and really trying to learn what it can give us. And I encourage you to look as carefully as you can with those results, because if we can get signals of subsets of patients that we can treat in a unique way, that are not just a list of anecdotes, it will really help move the field forward. So I think I'll close there, and I don't know if there's time for questions or later. That's up to you.